Hey, everybody, welcome back to the Overrun podcast. My name is Ed Bauter.
I'm Dan Schwester.
Mike
and
Defilippo.
our medical director, Mike Defilippo, is here with us again today. Mike, how we doing? How is life in the Midwest, my man?
Fantastic. Loving it out here.
It's all right.
You've been a
little busy. We know you're not used to the flow of the show, so it's okay. We'll get you back up. You've been doing some things. We'll give you a break.
I can't tell you how upset I am that you're the one in the middle of the country and you're tanner than both of us right now over on the coast. It drives me nuts. But
good Italian genes.
There you go. Gentlemen, we are gathered here today to talk about the newest updates the American Heart Association has put out to their cardiac guidelines, because we enjoy talking about hot topics here. So first, before we get into the really big thing that everyone's been arguing about on social media, let's talk about some of these basic updates that I think kind of cover everything that AHA should be covering. One of the biggest things they talked about, they focus a lot on systems of care. So Mike and Dan, we talked about this on the show previously. One of the biggest things is they're talking about naloxone for lay rescuers and increasing the availability, increasing distribution programs. Certainly something we've discussed on the show before, but it's great that AHA is coming out with some actual, ideas, protocols, guidelines for this. They're also including community CPR initiatives. They're talking about clinical debriefing, how teams should be composed, how on-scene arrest should work. They talk about eCPR, lots of really good kind of systems updates that I think are just important, and over the next 5 years are going to become more important. So what do we think about the naloxone edition? Does this fit, or does this add to the ideas that we've had where maybe AEDs just automatically have naloxone tourniquets, have like one BLS kit just kind of available?
Yeah, I mean, I'm pro all of it. I think public access for things we know that saves lives, that doesn't need a high level of investment or like learning beforehand, should be available. Most lay people, I feel like, would even know how to apply a tourniquet, maybe not like the tightest way possible. With community CPR teaching, I feel like having things that are available that you can use from your teaching, like an AED, like intranasal Narcan. I know there's some courses that teach all that sort of like bundled stuff together when they're going to do community teaching. That's what I do. I feel like that's the stuff that saves lives, right? Is like BLS CPR, tourniquets, and Narcan for people who are having a substance overdose. And it takes what? You can teach a dedicated grandma at a community center how to do all of that in about like 20 minutes.
Yeah.
If she's paying attention and you have enough time. So, I'm a big fan of just public access, all those things. And the dark reality, not to take this show so dark right at the beginning, is like, public traumas are becoming fairly more common with higher velocity types of weapons that usually need something like a tourniquet to control that bleeding. So, I think the more we have that publicly available, the more lives will be saved. So I'm very pro it, and I was very happy to see the AHA make those recommendations.
Yeah, I agree.
No, I think that's right, and you're right. Go ahead, Dan. You're coming to.
No, I agree. I think this is a low investment, high return thing. You're not going to hurt anybody by giving them naloxone if they don't need it, but for the person who needs it, it's going to be a good thing. AED is the same thing. It should be the same as fire extinguishers everywhere. We've known this for 25 years.
Yep.
It's good to see them finally coming out and pushing this. And I like the idea of, hey, it has to be a system. It has to be a team effort. It's not just one aspect of this whole thing. They reworked the chain of survival. I think those are good things. I think they're positives, and I think they have good benefits for the public as a whole.
No, I think that's absolutely right. And I think that throughout this update and throughout the paper, and there's an executive summary you can see. We'll link it in the show notes. The document itself is actually fairly long, but they focus a lot on team building, on, involvement of everybody. Even then, again, it's important to note that ACLS is not a pre-hospital skill. It's adapted for pre-hospital. It's also taught in hospital.
Right.
There's a big focus on teamwork for in-hospital cardiac arrest, on teamwork for out-of-hospital cardiac arrest. So it's really trying to, in that chain of survival, they're really trying to actually get everyone involved, which is one of the most important things, right? So the idea is you get the public involved, where they have access to an AED, naloxone, a tourniquet, and they start care immediately. Then we get there and continue the care and so on. Another thing that they mentioned that, and again, I keep using the word codified. This isn't a procedure. It's more like recommendations, more like guidelines, but they do mention that EMS systems should be prepared for on-scene termination. Not something that, it's not that they haven't mentioned this before, but again, kind of re-solidifying the idea of as a system, EMS are working on and we're treating kind of futile cardiac arrests. And while for years we've talked about it's more important to work someone on scene before you transport them, now AHA is kind of saying just work to termination or terminate the resuscitation if it's futile. Mike, working out in the field in a bunch of different states as you have, you probably have a better frame of reference than we might have because you've seen many different systems. What are your thoughts on that? Dan and I are both very pro that. I don't mean to speak for you, Dan, but I think typically working fetal resuscitation is not is not our bailiwick. But Mike, I want to know what you think about that.
Yeah, so I think it's a great recommendation personally. With the usual caveats, I'm very pro field termination. I'm trying to change the lingo. I'm one of a few people, again, with this stuff, field withdrawal of life support from an active cardiac arrest resuscitation.
Termination does sound like a little bit more, and I actually wonder how much of the phrasing that's used in documents like this affect how people think, because I feel you're right. I think termination of resuscitative efforts, while that's technically correct, it does kind of sound like we're like it, and while we are the ones making the decision, I suppose it sounds like we're the ones like, it's good enough.
Not to be that guy, but literally 2 weeks ago to the day today.
Actually,
we just published a editorial in Pre-Hospital Emergency Care discussing essentially lessons learned from intensive care in the hospital and how to reframe some of our thinking around pre-hospital termination and resuscitation in those terms. And one of the big points in the article is really about phrasing and shared emotions during those conversations, and really reframing it for patients' families and really the crews that are there too on scene. Of withdrawal of life support does say, look, we were providing life support, we were doing a lot of these things, and we've come to a decision, hopefully with the family involved in there, to say, pop wouldn't want this anymore. And your family can also see that, yes, we put a breathing tube in, we were doing CPR, we were giving medications, all those things. But, at this point, there's nothing else we can offer. So we're going to withdraw that life support and have you come to be at bedside with your family member, whatever it is. So all that to say, yes, I'm very pro it, with the usual caveats being, if there's a scene safety issue, right? Like,
sure.
I can certainly remember tons of jobs I was on in Newark where just, taking GSW patients off the because it's just unsafe to,
yeah. Hey, what if we're not here anymore?
Sometimes it's just safer to egress, right? So that's one. One area of conversation still too is with pediatric termination of resuscitation in the pre-hospital environment. Sometimes those scenes could be really hard. Often they're very hard. Usually it's not an expected death. Sometimes they are. So, there's lots of variables with those. So that's another caveat that I would say. Some people do by default transport pediatric cardiac arrest. That's also not my flavor. There's lots of studies out there about the shared trauma of doing things like that, meaning you're essentially taking a dead, kid and bringing them outside of that environment. Let's say the scene was totally safe and it would have been appropriate to pronounce that child, right? You're taking that kid outside of that environment. You're now transporting that baby or kid or whatever to the hospital, and sort of, just distributing all the people that are affected by one very terrible case where you already knew the outcome was not going to be good. So, there's not a lot of literature about pre-hospital termination of resuscitation in pediatrics and infants and neonates. That being said, taking lessons learned from adult termination, I think we can apply a lot of those same lessons. I'm very pro it. I have pronounced pediatrics in the field before. I do think it's an important thing if there's an EMS physician to be involved with that sort of stuff, just sort of, guide the conversation, or a senior paramedic or senior officer or whatever on scene to do that sort of stuff. Just because obviously it's a very, thankfully, low frequency event, but can be very difficult to manage and requires, towing the line very well. So those are my usual caveats. Outside of those things, I think, we are medical clinicians ourselves. I think we can determine whether or not someone has viability in resuscitation. And I think we can make that call and just pronounce them in the field.
No, I think that's mostly right. And again, Danny, we tend to go into scenes where, we'll walk in and you're kind of like, we already know where this is going to go. Mm-hmm. And this is kind of the intersection between the, medical legal side and the practical medical side, where there's concern that, there's maybe a lawsuit one day out there and, there's that specter, right? Perfect. And, we're the ones that are on scene working it. So I think it's important to kind of look at like, all right, maybe there's a litigious thing, but from the clinical care side of it, if someone has passed away in the field, sad as that might be, we really can't keep working them just for the sake of working them.
Correct. And I thought that was really good in the guidelines that they published. They talked about this and they said, listen, we're going to have to train our EMS clinicians to have these conversations with patients and families because we don't get this. And it's very hard in a clinical capstone or a truck rotation to adequately teach somebody how to talk to somebody. We've developed it because we've done it for years and we've failed at it a lot of
Yeah.
times. And
we had to.
and you still see it now. You see a lot of people once we get that pronouncement, it's very awkward. Everybody you can look around the room and you can kind of see who's dealing with it and who's looking weird. And, we need more training, we need more understanding. And I think the one thing that I thought about that they were soft pedaling, and I think the underlying thing, and I want to get you guys' feel on it. They're starting to give you the idea that not everybody needs to have CPR, that it is not going to work for the vast majority of cardiac arrests. We need to focus our efforts on what's survivable and what's not. And I thought that it was very, maybe I was crazy. Tell me if you guys don't agree, but I was reading this and I kind of got that like, hey, look, maybe not everybody should get CPR and we need to be able to suss out which patient populations benefit. Look, we know the 35-year-old who drops mowing his lawn. That's a no-brainer. The 85-year-old with dementia and the memory care that nobody really saw, and maybe this was a thing, but he's a full code and we're going to do this.
Right.
And
hasn't touched the call bell in 10 hours.
Yeah. I think we need to start changing this. And, Mike, I know you've been involved with this, and I just did a thing about it. We need to start thinking about identifying, just like we do with other procedures, who will benefit the most from that procedure and who stands to not benefit. Because we say in medicine, it's unethical to do things to people that don't have a benefit or will not work for them.
Except in cardiac arrest.
Yeah, we've all heard the jokes about, there's all sorts of jokes about it in medicine and it's gallows humor, but in reality, we got to start thinking about this. It's a procedure that works for a part of a population with a certain physiologic condition and state. It doesn't work for everybody. It's not resurrection. It's resuscitation.
That would be a great t-shirt. Right.
Metal as fuck, dude.
Yeah. Right. But I want to get into the big part about this that everyone's pooping their Pampers about in just a minute. But there are a couple little updates that I think are important for pediatrics. It's basically doing high quality CPR. If you have a pediatric patient you're doing CPR on, they want you to use multiple end titles before you terminate efforts. We just talked about that. They made it a point to add that if a patient is wearing a bra during resuscitation, it might be reasonable to adjust the pad position or the bra rather than removing it. Okay.
All right. They're just boobs, guys.
Sure.
Can we do this?
Yeah, okay. They made it. There's a line that we perform CPR the same way on obese patients as we would on non-obese patients, which sure. And then they have a vector change after 3 shocks for defibrillation, which we've talked about previously. So a lot of this, right, is data that we've been talking about on this show for years. Right. That has been out in conferences, right? All this stuff is kind of like rehashing all the old stuff. Mm-hmm. Now, let's get to the stuff that has been causing a problem on social media for the past couple weeks.
What, I haven't been on TikTok in a month. I don't know.
I know. Yeah, I haven't looked at anything. What I miss? So for those just tuning in, the EMS World Conference was in Indianapolis last week. Lots of good stuff comes out of EMS World the way it always does. I encourage everyone to check out all their socials. Our friend Jimmy Apple's got a bunch of really good stuff out on his TikTok. He's doing a bunch of interviews or did a bunch of interviews while he was out there. Yeah, really, really good content that comes out of it. And what everyone is losing their minds about is the American Heart Association in their 2025 update has removed the recommendation of mechanical CPR devices for the routine, underlined, bold, italicized use in cardiac arrest. So,
woo!
Yay!
Ask us how we feel about it. Yeah.
So this is it, and I think that was generally the initial feeling was finally, right? We're finally catching up to the data. I know I sent you guys text messages when it came out, and I want to give the AHA a shout out of credit because they dropped these findings in the middle of EMS World, which I know was not on purpose, but they dropped it during the largest international EMS
I almost wish I wish I was there. I am so sorry I missed this, just to see the disaster on the floor as it was spreading, right?
You start hearing like a din in the room and like everyone's looking at their phone, people start leaving.
Like the Rings calling the Uruk-hai.
Right. but just like that'd be so good if someone from the AHA walks out with like a shofar. Um, so, but again, like these aren't necessarily huge updates, right? Those that have been following the data kind of know that this is what's there.
Mhm.
But let's talk about what they actually said. Let's talk about what it actually means.
Yes.
So again, the phrasing that's in this actual document is we're not using mechanical CPR for routine cardiac arrest anymore. Now, as we talked about earlier, this might be kind of soft selling, no longer working, terminatable resuscitations. Maybe that happens in 5, 10, 15 years. Who knows? But it's saying to not use mechanical CPR for routine cardiac
It's a
arrest.
step.
To me, it is. To me, what that says is a routine cardiac arrest, by definition, are the majority of your cardiac arrests, right? The majority of our cardiac arrests aren't worked. So to me, it says that you shouldn't be using mechanical CPR devices on patients who are moribund in the first place, right? So that reminds me of like, the 95-year-old in the memory wing of a nursing home who hasn't been seen in, like I said, 10 hours, right? We don't use mechanical devices on them. The pushback has I don't want to say almost universally, has generally been that, well, what about this case? What about this case? What about this case? And the first thing I want to point out is you can find an outlier for any scenario, like any one, right? So you can find a reason to use or not use a device regardless of what the recommendations are. That said, what I think this new phrasing is saying is that this is a tool, and I hate the platitude of like, this is a tool in your toolbox, this is a weapon in your arsenal, but it's something that's available to use in the proper setting, right? So your refractory VF patients, your refractory VT patients, your patients who are witnessed arrests, your fresh kills, your young kills, whatever you got. And we have a whole bunch of stuff to get into it, but Mike, give me your 10,000 foot view of all this stuff. Did you jump for joy and open a bottle of champagne when these updates were announced?
Yes, very much that. I mean, it's no secret to you too, because obviously we talk about this quite a lot off the camera. But I'm a very big proponent of manual CPR as the initial CPR in most cases. I do think mechanical CPR devices do have cases, and I think some of those are prolonged cardiac arrest where the people just doing the CPR are going to get tired.
Sure.
You have special circumstances, maybe like some sort of exposure. So like even mentioned in the AHA guidelines was commonly in like an IR suite or a cardiology suite where someone may be in arrest, but there's lots of radiation exposure going on due to a procedure, it's more feasible to use a mechanical CPR device. And then certainly for pre-hospital stuff, I still think it's a very important tool in our toolbox because there's lots of odd scenarios that we run into. Sometimes you're not planning on transporting a cardiac arrest, but then you end up doing. So like if you have a prolonged transport, if you have prolonged scene time, if for some reason you're moving the patient, right? That's something we know we don't do good CPR on period when we're moving a patient, say down a flight of stairs, but maybe a mechanical CPR device does better. I would, asterisk my joy with saying that there are still uses for it. But, I do think that in one of the greatest, I got to be careful how I phrase this. One of the biggest upsets I would say in medicine over the last 10 years is the frequency in which mechanical CPR devices have replaced manual CPR for lots of reasons. I think let's take a look at, not dunking my in-hospital folks, because in-hospital folks do amazing work, but when you're comparing placement of mechanical CPR device from pre-hospital to in-hospital folks, there's a whole section in the AHA guidelines that talks about a study that looked at mechanical CPR ROSC rates in hospital versus pre-hospital, and pre-hospital was almost twice as much, if I'm remembering the numbers correctly, as the in-hospital colleagues. And some of the hospitals I've worked at, the ER doc responds to the floor codes or even up to the ICU and all that. And I've been in arrests in the hospital where it takes over a minute to get a mechanical CPR device on. And it's like, whoa, that's such a huge time off chest. So I think that's a big issue with it, in my personal opinion, is how long it takes for the device to get placed on, period. I think there are systems that do it really well. There's ways to train to do it really well. And I think in those instances, the time off chest is negligible. I've seen a Lucas piston put on in less than 10 seconds by a really, really experienced crew. So it is possible to do those things and really minimize time off chest. I think the other big issue that we're seeing, more so with the piston style devices as opposed to the circumferential or band style devices, is unintentional outflow tract obstruction with a piston. So just to refresh everybody's memory on what specifically I'm talking about. Obviously your blood vessels, your heart, your body is just a system of pumps and tubes, similar to how the internet is just a series of wires, or whatever Al Gore said famously back in the day. But
Thank you, Al Gore.
so yeah, bless up Al Gore, thank you. So sometimes what can happen is, obviously the heart itself is the pump, but when we talk about the outflow parts, so the aorta, it sits just above the heart. And whenever we're compressing the heart during CPR, blood is shooting out the aorta to perfuse everywhere else. Sometimes what can happen, both with manual CPR, if you're not careful, and with piston CPR, is that compression can actually happen on the outflow portion of the aorta, or what's commonly referred to as the left ventricular outflow tract, or LVOT. So if you have that, essentially you could be doing perfect CPR, but if you're blocking the exit path, that's not going anywhere. And that happens fairly frequently. Other things that happen fairly frequently, and again, in my opinion, with piston style devices as opposed to the circumferential band style, is that even though you may be doing compressions on the heart, maybe it's not in the right place. So, those are all things that I think manual CPR with good, feedback devices is a lot more beneficial and can give you a lot more real-time resuscitative data. I think there's, we'll talk about that later, but I was just going to say, so overall, I'm not a huge fan of mechanical CPR devices. They do definitely have their place, but for me, this was more fire for myself to advocate for manual CPR or hand CPR first, and then applying the Lucas or the Autopulse or whatever device your system may use second, if certain criteria are.
Yeah, I think an unintentional consequence of having all these automated CPR devices is that we decided that they're going to be this, this panacea, right? Where we're going to fix every cardiac arrest with this. And what tends to happen in these types of settings is, there's a new update put out and people will come back with their own anecdote, right? Or how often have we heard like, well, since I've started using the Lucas, I've had 90% ROSC, which like, no, you haven't first. But even if that's the case, I like changing the goalpost from ROSC to survival, right? Because ROSC is a benchmark it's a great benchmark to have for cardiac arrest, but it's a benchmark we have for us. Like it doesn't matter if the patient survives through the threshold of the hospital if they die in the ER, right? So adding these things and having
3 days later,
or upstairs or anywhere, yeah.
or
if they don't leave the
LTAC
hospital
6 months later,
yeah, exactly. If they don't leave the hospital with a CPC of 1 or 2, then it doesn't really matter. So Dan, I'm wondering, because from the pre-hospital side we see this a lot. As far as the provider side is concerned, I think there was a lot of panic when this came out. I tend to think a lot of it's budgetary. I think a lot of places probably dropped a good 6 figures on a bunch of CPR devices and then learned that they might not be efficacious. So if I'm running a system, how would you go to your staff and say, like, this is what the new updates are, and this is how we're thinking about, applying them or thinking about updating everything?
This is interesting because, again, if you read the guidelines and you read the stuff behind it, they're not saying throw these things out. They're saying they work in certain circumstances. And if you're in one of those systems where, hey, your interventionalist will take this person to the cath lab with mechanical CPR, hey, home run, good for you. That's great. That's a win. We'll get wins from that. My biggest issues with the mechanical CPR device is when you have people, and this kind of touches on the budgetary thing, and there are places where they say, hey, look, we bought all these things, you're going to use them. And we use them at the expense of common sense thought. There's a Dunning-Kruger. It's Dunning-Kruger writ large, Ed. It's the same thing as always. And we can go back to this with TXA. We can go back to this with intubation. We can go back to this. You name anything. It first comes in, it is the magic bullet. It will change everything and will make it work. Then we get into the valley of despair when we get the studies back and it shows, oh my God, these things aren't doing what we think they're doing. Get rid of them all. And the smart people come around to the other side, which basically is like, hey, we understand the science. We understand the background of this. There's things that this is for. There's things that this is not for. Everybody doesn't need an IV. Everybody doesn't need a needle decompression. Everybody doesn't need drug X. It's just how it works. And the mark of an intelligent clinician, or the mark of a strong clinician, is going to be the person who says, hey, you know what? That makes sense. We're not going to do this all the time. But getting back to your first thing, and the most important thing I would do is, if I was the chief of a department that had these things, first and foremost, my people would be absolute masters at manual CPR. They should be able to get on a mannequin and run a strip perfectly every time, no fail. And we would take pride in that. We are excellent at this. And we would teach in the community, and we would go out and go to these neighborhoods, and we would show them the proper way to do it. If I made the investment in these things, I would be looking to, and yes, I would be researching what patient populations benefit the most from this. What do my hospitals have in the way of, will you take this person? Will they go to the cath lab? What are you guys going to do when we come in with that, Autopulse, Lucas, whatever you want to call it? What are you going to do with it? How are we going to make this work? We have a tool.
Right.
We want to utilize it to its absolute effective maximum. How do we make that happen? And unfortunately, what the AHA did say, and then I'll just throw it to you guys, because Mike, I want to get your take on this. The AHA really acknowledged that the data is not there for these devices. Most of the data you see, and I can tell you because it's competency season in my shop, and I've been through the talk 4 times, and I can tell you the data that they're putting up on the screen when they're talking about this with us, there's a lot of bias. There's a lot of problems with these studies, and they're pig studies. And hey, look, I love conceptual stuff. I love doing conceptual things, but it doesn't translate to the real world, and we have to be aware of that.
Yeah, it was one of the only studies that showed it. So, and no, Mike, I want to get into these trials here, like Link, Paramedic, Circ, because again, we've talked about these on the show before, but I want to kind of get everything into one central thing here, because as we've said several times already, and I hope it's been enforced enough to the audience, this isn't new. None of this stuff this isn't new data. This isn't new information. And as far as like the equipment and the sunk cost fallacy and all of that, I will give you targeted temperature management. I'll give you your IV pumps. I'll give you all of these things that you do not use regularly,
Goal-directed
but
therapy.
are essential, right? But are essential when they work. Right. This is not the first time that we've said that something might work and then we learned it didn't work as effectively as it did. Again, TTM is a big thing. Right. So, but let's get into these actual RCTs. Like, what does the data actually say? So, Mike put a really great rundown together here. Let's talk about some of this evidence base here. Let's talk about what the AHA and ILCOR have actually said in 2020, 2025. And let's start there, right? Because I don't want the impression to be that AHA just kind of came out with this willy-nilly.
Yeah. So, I mean, a lot of this was really funded. I think, really commend the AHA on their due diligence. I actually think every time they put out a guideline update, it's very well researched, very, very well, like consensus. Obviously.
And not to step on you, Mike, but they're also a very conservative organization, and they do that for a lot of reasons. Obviously, like people like us are never going to think they go far enough, but they have to almost, by rote say like, yeah, we know what the data says, but we have to kind of wheel it back a little bit so that people just don't literally throw out their auto.
Yeah, you can't turn the ship 90 degrees. You turn it 2 degrees, and then you turn another 2 degrees, another 2 degrees, and we get there.
I turn it 90.
Nice.
No, I'm just kidding.
Put it right on.
I do what I
just
want.
throw it.
Yeah, you can tell he's in like he's not near the ocean anymore. He's just near rivers. He's like, yeah, I know. I turn it 90 degrees. It's fine.
Ski this thing.
Whip that bitch. No, I'm just kidding. But yes, I mean, we already touched on a lot of this, but the most recent guideline updates, obviously, against routine use of it. So what did they base that off of? There was 3 major RCTs that they talk about: Link, Paramedic, and Circ. All of them showed really no improvement in survival of discharge or neurologically intact. And if you look at a lot of the studies that are done on ROSC or neurointact survival or anything like that, when it's comparing mechanical CPR to manual CPR, a lot of those are what's called a non-inferiority study. And what does that mean? That just means, is this other intervention? So we know something that works, right? We have CPR. We know CPR works. But we have this new tool, mechanical CPR, or like robot CPR, whatever name. Robot CPR just sounds more fun to say, so we're going to use that. So we have RCPR, robotic. Open CPR, Open AI.
We can make that. This is the Resuscitation 2000.
The rosker. So Yeah. So non-inferiority trials essentially just say, we know something works. Let's compare this new tool or this new approach or new whatever, just to see, like, essentially, is it just as good? Is it worse? Is it better? We don't know. It doesn't really say, like, definitive things about it. It just gets, some data and says, okay, it's not inferior. That's essentially what a lot of these studies showed. It said, we have this new CPR device, non-inferior to manual CPR, which for us emergency researchers and emergency clinicians, that for us is like, okay, let's see if we can do maybe some prospective trials, integrate this into protocols.
And also, like,
it's a safety profile.
Non-inferior is Coke or Pepsi.
Essentially.
Like that's what it is. So, like, I just want to clarify
about it.
Yeah, it's not, this works this much better, or there's no like percentage number, right? It's essentially like either or.
Well, just
right?
because this isn't worse doesn't mean that it's not that.
Right. Doesn't mean it's better.
I mean,
exactly.
That's
why
inferiority says.
That's why I use
this is worse than manual CPR, and they were saying no, it's not. But that doesn't mean it's better.
Some days I prefer a Coke. Some days I prefer a Pepsi.
That's what I'm saying, and that's why I use that analogy where it's like, you should be doing manual CPR, but if there's a setting in which that won't work, you can use mechanical CPR.
Right.
100%.
Right.
Yeah. And so all those major RCTs, again, that was the Link, Paramedic, and Circ trials, really just showed that there was no necessarily improvement or like significant change. So really, like, the key takeaway for that, I would say, is either way you cut it, survival still just hinges on high quality CPR, whether that's using a mechanical device or you use your hands. So, again, what else did they look at in this sort of stuff? Looking at our survival and neurological outcomes, AHA did get with the guidelines database. So they collect everything, see how people are like adhering to guidelines, what sorts of things happen when you're following AHA guidelines versus deviating from them. All that to say, they looked at mechanical CPR and they found, interestingly, when in hospital cardiac arrest, lower survival to hospital discharge compared to manual CPR. And it was a pretty big change. So here's the actual numbers. This is what I was referencing earlier. It was 11.8% survival in the mechanical CPR and 16.9% survival in the manual CPR. So, those could just be some percentages out there, but it's a fairly big difference, in my opinion, of you're essentially having 1 out of 10 patients survive versus whatever 15, 17%. Almost 1 out of 5.
Right. And just to clarify, again, cardiac arrest survivability is still phenomenally low. Like, just so we're clear on all of this, it's not as if over the past 5 years, we've been crushing it with cardiac arrest and we have a whole bunch of people that are surviving to discharge. No, it's quite the opposite. So this whole thing.
And importantly too, none of this talks about survival to discharge CPC 1 or 2.
No.
Correct.
Which is all
that matters.
That's how we're...
It doesn't matter if we bring somebody back if they're so anoxically brain damaged that they have to live with a tube in their stomach and a tracheostomy to survive, and they're just waiting for that pneumonia or something. What have we done? We haven't helped anyone.
And just as a clarifying 100%. Point, again, like this isn't saying, don't work on someone when the family is there. Like, obviously there's outliers, there's always exceptions, right? And this is the thing that, like I said earlier, that's been driving me nuts, and this came out. Like, there's no way that you can account for every scenario.
100%.
There just isn't, right? So when AHA puts out a paper that says we don't want routine use of mechanical CPR, and someone says something like, well, what about the 15-year-old who goes into cardiac arrest at a high school basketball game? Okay, use it then, I guess. It's really difficult to explain everything, where it's like, all right, listen, there's these other concerns that you have. But no, so again, so just reinforcing, like, all this data has been out. This isn't new stuff.
Frustration, right? Because that's what, Anna was down at EMS World Ed, and if you remember, she was sending us messages going, oh, there's guys walking by the Lucas, people making fun of them and going, oh, better throw those out. Like, that's not what they're saying. It's just.
I mean, listen, there's a part of me that thinks that's kind of funny. I think it'd be funny to walk past a booth and it's kind of like lay a bouquet of flowers. Get one of those big, like, horseshoe grave blankets.
Sarah McLachlan CD, start playing Sarah McLachlan in the background.
And speaking, yes.
Give me a black and white commercial of Lucas and Autopuls with eyes of an angel playing
on a rain-swept street in front of a chain link fence. There's just a Lucas put up next to a garbage can, like, in the arms of Stop it.
Oh man.
That's a good segue into, they talked about the different types of devices as well in these guideline
Yeah.
updates, which I think is really good. So obviously there's two categories, which we've already sort of alluded to, that people have: your load distributing bands, or what I like to refer as the circumferential compression devices, and then your piston driven. So your circumferential compressions, most people call the autopulse, and your pistons, most people refer to as the Lucas device. So the data really doesn't show one is superior to the other. Um, I personally favor the circumferential compression devices for what I alluded to earlier. I think, in my opinion, the piston devices just have a higher rate, in my anecdotal experience, of causing functional left ventricular outflow tract obstruction.
Well, it's even
So
mentioned
I
in
don't
this
like using
update
it.
that piston-driven devices might be better off placed laterally to the sternum. Like even within this update, that says mechanical CPR isn't recommended routinely. It says if you're going to do it, you should laterally place. Like there might be a value to laterally placing the actual piston. So again, like within this study, this guideline set, it's like, don't use this device, but if you're going to, we've been using it wrong.
Correct. Yeah. And I think the other big thing that they highlighted here that I'm a huge fan of is that device deployment, like putting the actual mechanical CPR device on, needs to happen during planned pauses, meaning you're not interrupting an active compression cycle because Joe Schmo just walked in with the Lucas device. You're planning on when to putting it on the patient. And that should, in an ideal system and in an ideal world, be trained and simmed several times before it's deployed in the field. So everybody is on the same page in your system and saying, we know when we pull up on scene, if it's an active cardiac arrest, we're going to do 2 cycles of manual CPR. If at that point folks are starting to get tired because we're already high performing and doing pit crew style or whatever it is, then during one of the pauses, 10-second pauses, and we're going to train down to get this time down pat. Shout out Albuquerque Fire Rescue. Those guys had it down pat. You
Who
lift the
trained them,
patient up,
Mike? Who
throw
taught
the
them to get?
Lucas, you throw the Lucas on them, and you get the patient on that device really rapidly. And that requires a lot of training. It kills me inside to see such long off chest time because people just don't know how to get the device on.
And you're right. I think that's definitely a training component that needs to be added to it. And when we talk about the training component, because again, this is another thing that's mentioned in AHA, that you need to have good pit crew CPR, good training. What they're talking about is not going into an office and running through your standard mega code, right? Where I think there is a value to having like that kind of passive session where you're like, all right, how would you run through this ACLS mega code, right? But what they're talking about in practice and in training is you have a mannequin that's on the ground. You have someone at the head for airway. You have 2 or 3 more people like doing the way that the AHA actually recommends doing ACLS and PALS, where, all right, stop. Now we're going to roll the patient, you have to have that closed loop communication of getting everything done. On scene, we're very bad at doing that, doing part to the chaos that's on scene or whatever else. There's a million reasons that we have a lot of trouble doing that. So one of the last things before we get out of here, Mike, one of the lines that we have here in the rundown is using mechanical CPR for logistics, not outcomes, and train like your patient's brain depends on it. We kind of touched on this earlier where I think a lot of times in resuscitation, we're doing it for us and not necessarily for the patients, but the train like your patient's brain depends on it because it does is a very, I think it's a very salient point. So I want to get your thought on that. Give me, a back of the coffee mug type of quote I can give people to start training their crews.
Yeah, I mean, just like any other high risk intervention we do, just because it's fairly routine for us because we run a lot of them, cardiac arrest management has high stakes, and really improper CPR, time off chest, those are the things that kill brain tissue, kill cardiac tissue. So if you get the basics down, I'm a big believer, since even when time I was a paramedic, BLS very, very much before any advanced procedure, and really consider mechanical CPR an advanced procedure, despite who's deploying it, BLS agency, bystander, whoever. Make sure the basics down pat first, that you have good compressions, that you have good chest recoil or chest compression fractions good. You're doing all the right stuff first with all the right stuff in mind. And what I mean by that is, have a little mantra you say to yourself. Like I tell myself all the time during a cardiac arrest, time off chest, time off chest, time off chest. Because for me, it doesn't matter what fancy doctor shit I'm doing. All that's sort of like supplementary to doing good CPR in those cases. Study after study shows, doesn't matter if we tube them or we don't tube them. Doesn't matter if they have an IO or an IV. Doesn't matter if they get epi or not. Things that save lives is early defib CPR. So I think going in with that mind frame of, this is brain tissue that depends on it, like cardiac tissue that depends on it, like we treat STEMIs and strokes and all that other sort of stuff. Know the basics first, do them solid. That's the stuff that actually saves lives. manual CPR hashtag. I'm a big fan.
Make
I don't know where
BLS
you're getting your
great
data from, but wow, make BLS great again. I don't know what you're talking about, Mike. My intubations save lives. I don't know.
Oh,
I don't know
absolutely.
about anybody else. I have a 100% first pass success rate. I've also never missed an IV in my life, so I'm very good. I'm very good at cardiac arrest. Danny, what do you got?
No, I think this is all great stuff. Again, it comes down to the fundamentals. It's great. And, I'm going to use a football analogy because we're in football season, right? Hey,
Go
look,
Birds.
it doesn't matter if your quarterback can run a West Coast offense. Here's the problem. If your lineman can't block and your receivers can't run routes and
Yeah.
your defenders can't tackle, you ain't going to win. It's the fundamentals that matter. And it's the same thing here. All the cool stuff, all the magic doesn't get to happen until somebody is doing good CPR or good BLS and gives them somebody viable to work with. If we're not doing that, all the rest of this stuff is just window dressing. It's just playing games of futility. And that's going to hurt us in an industry where we're not getting the people coming into the job that we used to. People are leaving the job. We have attrition rates. We can't afford to be doing this to our clinicians all the time, where they're just going to go, you hear it now. We already hear it, like, oh, it's cardiac arrest. Oh, they're dead anyway. What's the point? And that's the worst way to look at it.
There's a huge section that we haven't even touched on because the AHA doesn't mention it when we get into, provider fatigue and burnout and any emotional damage and all that other kind of stuff. But I mean, Mike, you can make the argument that maybe it's like a running back trying to score a touchdown on one good leg.
Too soon, man.
Come on.
I'm sorry.
Don't do my boy.
I had him
like that.
I had him on my fantasy.
I can't hear any of you over the Eagles in the top of the division. Go Birds. Hey, everybody, listen, we're going to be presenting at conferences this year coming up. If you're going to be in New York, I'm going to be presenting at Vital Signs. And if you're going to be in New Jersey, come down and see us in Atlantic City. We're going to be down at Harrah's at the National Conference for EMS presenting as well. Come on down, say hi to all of us, and we'll grab drinks or whatever we do in Syracuse and in Atlantic City. For the Overrun, I'm Ed Bauter, Dan Schwester, Mike Defilippo. We're all here. Follow us on all the stuff, and click the things, subscribe, check out all the notes in the show notes.
Would you please?
Yeah, let us know what you all think about these updates. And I'm sure we all have our own opinions, and we're going to keep following up on this because these are updates that are not going to change.
We didn't even talk about it.
Dynamic. We haven't even gotten to half the drugs, so I'm sure we're going to have more.
Yeah, we didn't even talk about the exploding hearts. We forgot to bring that.
We didn't get into that at all. Lots of data to talk about here, but again, the big important thing is mechanical CPR can still be used. Just don't use it on everybody. Use it as a tool the way we use everything else. For the Overrun, this is all of us. Thanks so much for listening. Subscribe down below and be on the lookout for Monday Afternoon Journal Club and all of that. And we will talk to you next time.